Hi, everyone. My name is Bill Collar. I'm a business development manager for Ortho Illinois. I wanted to thank you for taking time out of your busy schedule to join us for another Ortho Illinois Power Lunch. Today, we're talking with Dr. Jeffrey Kazaglis, who will be talking about common sources of shoulder pain in workers' compensation. Before we get started, our non-discrimination statement. If you do have any questions or problems with the webinar, with the presentation, if you don't have access to it, please do contact me, Bill C. at Ortho Illinois, so that we can take care of any issues that you might be having. If you have any questions as we go along with our live webinar, please use the Q&A section at the bottom of your screen. It's probably at the bottom of your screen, depending on your settings. But just click on that, type in your question. Dr. Kazaglis will answer those questions after the end of the webinar, but we will get to those. So please think hard about what questions you would like answered. Also, after the webinar, you will have a link to our evaluation page. That link will provide some continuing education for you. Our keyword for the continuing education is shoulder. You will need that in order to get the CEU credits. That link will open automatically right after the webinar. If you do miss it, you will also get a thank you email in about 24 hours where the link will be provided. If you happen to be watching this on our YouTube channel, it's not live, and unfortunately, we will not be offering the continuing education credits for the recorded session. If you have any other questions as we go along or after the webinar about workers' compensation referrals, or if you'd like to learn a little bit more about our fast track program for work-related injuries, please take a look at our website, orthoillinois.com. You'll click on the employers tab where we have all sorts of information for you to go through. You can also call our main phone number, 815-398-9491. If you work or reside in the Algonquin, Elgin, McHenry, or greater Chicagoland area, please call Paul Strandquist. His direct line is 815-847-7088. Or in the Rockford or North Central Illinois area, please give me a call. Bill Collar at 815-847-7044. And without any further ado, I'd like to introduce to you Dr. Jeffrey Kazaglis.
Good morning, everyone. I want to thank you for joining us today at Ortho Illinois. And our lunchtime webinar today is going to be talking about common sources of shoulder pain in workmen's compensation. I'm Dr. Jeff Kazaglis. I'm a sports medicine specialist with Ortho Illinois, and I have offices in Elgin and Algonquin. My professional background, I've performed about 2,000 shoulder procedures. That includes arthroscopic procedures like rotator cuffs, capsular releases, and subacromial decompression. That also includes fracture work on clavicles and proximal humerus, as well as shoulder replacement. I'm board certified both in orthopedic surgery and orthopedic sports medicine. I was a military officer for 14 years, and I was in the infantry as well as the medical corps. And my last job in the military, I was the chief of orthopedics for the 1st Infantry Division, which is known as the Big Red One, and traces its origin all the way back to the Continental Army. It was the 1st Infantry Regiment raised by George Washington. So things that we'll be going over are the history, how you got hurt, key topics on physical examination. I'll review some relevant imaging studies. We'll go over conservative treatment, and then I will review some surgical cases that I did. So when I say history, as you know, means how did it start? And there's 2 types of problems in the shoulder that can arise. There's acute problems, and there's more gradual or chronic problems. Acute onset problems would contain fractures, for example, whether that's of the proximal humerus, the collarbone, or the upper arm, or the shoulder blade. Rotator cuff sprains, where you partially tear the rotator cuff from a variety of injuries. Separating the acromioclavicular joint, otherwise known as an AC separation, as well as actually dislocating or popping the shoulder out of place. More gradual onset injuries can include tendonitis, like rotator cuff tendonitis or biceps tendonitis. Sometimes patients can flare up underlying osteoarthritis, which can temporarily cause dysfunction in the shoulder. And finally, we'll talk about frozen shoulder, which is otherwise known as adhesive capsulitis, which is a process where the shoulder, often due to some minor insult, will develop some inflammation in it, which results in significant pain and stiffness. It's okay. How you doing? I'm Dr. K. Good to see you. We actually have a person who stopped in to listen live. So are you gonna be good there? Okay. Do you want to just listen? I'm not sure if you can. Yeah, you got to turn that off though. Thanks. It's okay. Welcome. What's your name?
Natalie, I'm here with your next.
Oh, okay, Natalie, it's nice to meet you. Or
Early,
it's
so
a-
watching you on here.
It's okay. We have a live participant, everyone. That's okay. We'll talk about patient age. So in the shoulder, there's kind of a dividing line. Certain conditions affect people 35 years and under, and then other conditions will more commonly affect patients 35 and older. Under 35 years of age, more common acute injuries include dislocations. The dislocations that usually happen the most frequently is an anterior shoulder dislocation. That is one, I'm going to bring my arm up, where somebody falls with their arm up and out to the side. And when they fall forward, the arm gets pulled back and the shoulder pops out the front. Sometimes people can also tear or dislocate the shoulder through a throwing type mechanism. AC joint injury, like we spoke about, is when somebody falls directly on the tip of their shoulder. Rotator cuff sprains are common in young people, but under 35 years of age, it's very uncommon to see somebody with a complete rotator cuff tear that would require surgery. Fractures of the proximal humerus is usually more of a high energy. That can be a fall from like a ladder, a car accident, or an industrial injury. Over 35 years of age, patients can still get the things that younger patients get, like a dislocation or a fracture, but then there's some other conditions that start to come into play. Frozen shoulder is, like we spoke about, where you develop an inflammatory process in the shoulder, often with a minor trauma, like you're reaching for something or pick up a heavy bag. Sometimes I'll see people who work at the airport, baggage handlers who will develop this. But the cardinal thing about a frozen shoulder is stiffness. First, they get pain, then they get stiffness. Because the shoulder's stiff, they can't move it. And that stiffness results in more pain and more inflammation. One of the most common conditions that I see people for is called impingement or inflammation on the rotator cuff. That's probably one of the most common things that workers will develop, because that can be due to a variety of things, such as a reaching or a pulling injury. It can be due to a repetitive thing. I have workers, I'm going to lift my arm up, who will work in an assembly line, holding things overhead, who will develop inflammation in the rotator cuff. Sometimes shoulder arthritis can get flared up as well, whether that's in the collarbone joint, the shoulder joint. And one of the cardinal things that happens with that is there'll be some grinding in the shoulder. So we're going to jump ahead to physical examination. Physical examination encompasses a few things. One thing is visual inspection, where we actually look at the shoulder, palpation of tenderness, where we're feeling around the shoulder for the areas that hurt. Active motion is where the patient moves their arm. Passive is where the provider actually provides the fulcrum or the motion to use the arm. Manual muscle testing is assessing the strength of the areas. And then I have some special tests that I'll go over. So visual inspection is, you have to see it to diagnose it. So if a male patient comes in, I'll have them take off their shirt. If a female patient comes in, we'll either put her in a gown, or with a chaperone have her in a t-shirt or bra. But we want to actually see the entire neck, upper back, and shoulder girdle. With an acute injury, sometimes we're looking for bruising or ecchymosis. And with more chronic injuries, sometimes we could see someone with significant muscle atrophy. And I have a few examples of that coming up. So this is a patient, he came to see me. He was actually a tree trimmer. And he said that he had fallen 6 months ago and had a burning sensation in his shoulder and was having trouble using the overhead chainsaw. And when I had him take his shirt off, we're looking at him from the back. And if you look at the left shoulder blade, that has a normal shape. If you look at the right shoulder blade, the acromial spine is very prominent on that side. And just below that acromial spine, there's a hollow. And that's a space where the infraspinatus muscle should be. And basically, he had stretched the nerve that delivers electrical signal to that muscle, and that muscle had completely atrophied at this point. This is a view of him from the front, and just looking at his right side and left side, you can see significant asymmetry in the musculature between his right arm and left arm. And in addition to stretching the nerves that go to his rotator cuff, he'd actually stretched all the nerves on that side of his neck and had a brachial plexus injury, and was just coming to see me late for that. I was actually a second opinion. Another provider had seen him and diagnosed him with a rotator cuff strain. And I had asked the patient, did he ever have you undress? And the patient said he had not. So that's why it's important. You have to see it to diagnose it. So when I talk about palpation of the shoulder, that is, as you know, where you're touching the different areas of the shoulder. So there's different areas of the shoulder that classically will relate to underlying pathology. Lateral pain, or the top of the shoulder, often is rotator cuff pain. Posterior pain in the back of the shoulder can also be rotator cuff pain, but sometimes people can develop a cyst that develops because they'll tear the connective tissue or labrum in the shoulder, allowing fluid to leak out of the shoulder socket. That fluid then creates a little pocket in the back of the shoulder blade. That pocket then pushes on a nerve that results in muscle atrophy. Superior, I'm going to put my finger on the top of my shoulder. That's usually when people separate their shoulder, it'll hurt on the top of the shoulder. Upper arm is kind of going all the way down the side of the arm to the elbow. Sometimes people who have inflamed bursa or subdeltoid bursitis can have pain that radiates all the way down to their elbow. Is that visible on the, okay, just making sure. Sometimes anterior pain can be the labrum, which is a structure to stabilize the shoulder in the front, the rotator cuff. I don't have it listed there, but also the biceps tendon can be a common source of pain in the front. One thing that I do with every patient that I evaluate for shoulder pain is I'll do a cervical spine exam. Well, I'll just make sure that the range of motion is smooth and we're not getting referred pain. Next thing that I'll check is the range of motion. Active motion is where they are moving the shoulder. Passive motion is where I'm moving the shoulder. If a patient has limited active motion and limited passive motion, it's usually due to one thing. Most commonly, it's a frozen shoulder, otherwise known as capsulitis. Most of the time, if somebody has a fracture, we'll know it coming in. The last thing that can limit motion, both to active and passive movement, is shoulder arthritis. So this is a gentleman who subsequently had a shoulder replacement, but if you look on the slide, on the right arm, I'm able to externally rotate his shoulder almost 90 degrees. And on his left side, I'm not even able to externally rotate his arm at all. So we talked a little bit about history. We talked about physical examination. And I want to talk about diagnostic imaging. Radiographs I will obtain in every patient that I see with shoulder pain. A true AP is an X-ray that's done at a little bit of an angle to the chest. And that gives us a true view of the shoulder socket. I bring that up because sometimes patients will arrive to see us with X-rays from an urgent care center. And often my practice will repeat the X-rays because we're looking for specific views that give us information about the possible sources of their shoulder pain. An axillary view is an X-ray done through the armpit that lets us get a feel for the relationship between the ball and the socket. A scapular view is one done where the patient turns their body 30 degrees, and that gives us a picture of the shoulder down the axis of the acromial spine and allows us to see if someone's acromion is flat or if their acromion has a bone spur on the front of it. Very rarely will I get an MRI the first visit. Most of the time I'll get X-rays, evaluate the patient, do anti-inflammatories, do physical therapy, do modified work, and sometimes a cortisone shot as well. When the patient comes back for a second visit, if their pain persists, that's when I'll often get an MRI. Third thing listed there is a CAT scan. That's not done a ton with shoulder pain. Sometimes we'll do it in the instance of a shoulder fracture, which gives us a better delineation of where the broken pieces of the humeral head will be. Doppler scans are done mostly for the lower extremity, but every once in a while, we'll have a patient come in with a swollen arm and be concerned about an upper extremity blood clot and get a Doppler. Ultrasound, I'm not a huge user with ultrasounds after surgery, but some people will assess the integrity of a rotator cuff after surgery with ultrasound studies. I usually don't feel that's necessary unless the patient has had a significant change in function. Then sometimes we'll do an ultrasound or even a follow-up MRI if we're concerned that they've re-injured the rotator cuff. So rotator cuff tears. Most of the time under, and I have a couple slides coming up with some pictures of it, but most of the time under 40 years old, it'll be a partial tear. Over 40 years old, it more often could be a complete tear. The rotator cuff is not a point in time. It's more like a book with 100 pages. So it has a top cover and it has a bottom cover. And you can tear all 100 pages or you can tear just a few pages. Most of the time, if you tear less than half the pages, it does not require surgery. And for at least a few months, you'll try conservative care. The primary indications for repair of a rotator cuff are number one, relief of pain. Number two is restoration of function. So here's just a slide that goes over some of the anatomy of the rotator cuff. Bill, I'm not able to use a pointer, am I? Okay, sorry about, that's one of the downsides of webinars with the pointer, but we're looking at a patient from the top down. So we're getting what we call a bird's eye view. The front is where his chin is, the back obviously is where the back is. The one thing that I wanted to show everybody is there's actually let me do it better this way, 4 rotator cuff muscles. There's one in the front called the subscapularis. There's 2 on top called the supraspinatus and infraspinatus. And then there's one on the back called the teres minor. The subscapularis actually pulls the arm into the chest. The supraspinatus and infraspinatus bring the arm away from the body, and the teres minor helps bring it away from your body when your hand is down by your butt. So let's talk about subacromial impingement. Subacromial impingement is when the rotator cuff gets inflammation from either overuse, trauma, or sometimes it's just age-related. It can be related to bursitis, which is an inflammatory process in the fluid sac that goes between the acromion, which is the bone on top of the shoulder, and the rotator cuff. There's a fluid sac in the shoulder that allows the rotator cuff muscles to spin around the shoulder bone, and it provides it with a gliding surface. Sometimes that bursa can become inflamed, and that's when somebody has bursitis. What I said earlier was that some people have a spur coming off the top of the acromion, which can rub the rotator cuff when it goes underneath it. So this is a picture. If we imagine that there's a clock on the picture, there's a little black dot at the 12 o'clock position. 6 o'clock is on the bottom. As I'm looking at my slide, 3 o'clock's on the right and 9 o'clock's on the left. If we look at about 1 o'clock, there's 2 bones coming together, which is the acromion and the clavicle. And they're reaching down almost like thumbs, and they're creating an indentation that's rubbing on the supraspinatus tendon, which is underneath it. So sometimes people will have a spur that's not symptomatic, and sometimes they won't. There is one condition that I look for. Every once in a while, I'll get a referral for someone for a broken shoulder, and it'll be an ossicromiale. An ossicromiale is a condition that about 3 to 4% of Americans have, where the front corner of the acromion is actually not fused to the bone. So instead of it being one piece, it's actually 2 pieces with a fibrous union. And sometimes on an X-ray from the emergency department, it'll be misdiagnosed as an acromial fracture. So a couple things with subacromial impingement is there'll often be tenderness in the front of the shoulder. Sometimes external rotation will be weakened. One thing that we always look for is there instability of the shoulder? That's where the shoulder is slipping in and out of place. Very few patients I see outside of those with an acute dislocation will have that. So this is me testing someone's external rotation strength which is testing the supraspinatus. This is testing a specific muscle, the supraspinatus. We call this like the flying wing, or kind of like for an Eagles football game, fly, Eagles fly. This is a test where we have them put their arms out to the side and turn their thumbs down to the ground. This is a patient who actually had a mastectomy for breast cancer. And when you look at her shoulder from the back, her shoulder blade on the right is very prominent. Her shoulder blade on the left is normal. What's happening with the shoulder blade on the right is that the muscles have been paralyzed during her mastectomy surgery. So that shoulder blade, instead of being locked against the back of the chest wall, providing stability from the shoulder, gets pulled away from the chest wall. And that's somebody who has a scapular dysfunction. This is a slide of a test that we look for rotator cuff impingement, called a near impingement test, where we bring the arm overhead. And if a case manager is with me during an evaluation of a patient, you'll see me do that every time. That is a good test to look for a bone spur that's inflaming the shoulder. This is just another test called a Hawkins test, which is also kind of a secondary test that we can do for rotator cuff impingement. So to bounce ahead, what do we do for impingement? I will try conservative therapy 100% of the time. That will include physical therapy, anti-inflammatories, and an injection into the subacromial space. Usually the injection is done with a combination of xylocaine, which is a short-acting local anesthetic, Marcaine, which is a longer-acting anesthetic, and then a water-soluble steroid. I generally warn patients that they're going to be sore for 2 to 3 days with the injection, that normally in the next 5 to 7 days, we can expect some significant pain relief. A subacromial space injection, most of the time, will give at least a 50% reduction in pain. If the shot works, we also give anti-inflammatories and physical therapy. We modify their work profile and usually see the patient back in 3 to 4 weeks. When they come back in 3 to 4 weeks, if they got no relief from the shot, therapy, and an anti-inflammatory, then normally I will order advanced imaging. So let's say this is a patient I saw who had 6 weeks of conservative therapy. They had had an injury at work where they fell off a cart and hit their arm on the side of the floor. When I saw them initially, they were able to actively lift their arm up. Because they failed a shot, anti-inflammatories, and physical therapy, I ordered an MRI. The MRI in front of you, we're going to use our clock face again. 12 o'clock's the top, 3 o'clock's the bottom. And if you look at the black stripe coming on the top of the humerus, over at about 2 o'clock, there's a gap between the black tendon on top of the humerus and where it should insert on the right side by the greater tuberosity. So that's a full thickness rotator cuff tear. The MRI gives us 3 important pieces of information. Number one, it shows us how big the tear is, how big the gap between the tendon and the bone is. It shows us the location of the tear, where it's coming off the greater tuberosity. And it also shows us the quality of the muscle. Sometimes if a patient's had a long-standing rotator cuff tear, the muscle is completely atrophied. In those situations, fixing the rotator cuff may actually not help them at all because the muscle is no longer functioning properly. This is another example of a patient that I operated on that had a full thickness rotator cuff tear. And if you look at the humerus in this situation, the humerus bone is actually migrated superiorly above the central axis of the glenoid. Normally, if this is the glenoid, the humeral head sits right in the middle of it. If the rotator cuff's been torn for a long time, the humeral head can migrate superiorly, which is what we see in that slide. So I probably do about 100 to 150 arthroscopic rotator cuff repairs a year. I've been in practice for 18 and a half years. And when I did my training, arthroscopic rotator cuff was actually a very new thing. And as technology has improved, our ability to diagnose and minimally invasively treat rotator cuff pathology has improved. I probably open 1 rotator cuff every 3 years at this point. Arthroscopic repair usually results in less pain initially. I think it's a quicker recovery. And the best part about it is that it allows us to identify other associated injuries that normally we wouldn't see if we just make an incision to repair the rotator cuff. So when you do a rotator cuff or any other arthroscopy, there's basic techniques. This is a view of a patient from the side, and we're looking at the arthroscopic portals in the shoulder. The drapes that you see is how we normally drape someone in the beach chair position. We're going to go over just briefly the instrumentation. Sorry about that. The anesthesia, how we position them, the portals, and then how we actually repair the cuff. So the anesthesia that we do usually is two parts. There's a general anesthetic where they go to sleep, but there's also an inner scaling, which is an injection done by where the brachial plexus comes together. And that way, when the patient wakes up, they don't have any postoperative pain. So generally, a combination of general anesthesia and an inner scaling works best. This is called a beach chair position. This is a special table that hooks to a normal operative bed, and it has something that holds the head and keeps the neck from rotating, keeping it in neutral alignment. And then you basically sit the patient up with a pad under their knees. This is how most people do rotator cuff repairs. Now, when we talk about portal placement, that is a shoulder where I marked out the bony anatomy with an indelible ink marker. To the left is the front of the shoulder, and to the right is the back of the shoulder. And on the side are the three lines. So normally, we'll start off with an incision in the back of the shoulder that we put the camera in to look around. Then we'll make an incision in the front of the shoulder to put devices in. And then we'll use a side portal to address the rotator cuff. And then if we have to repair the rotator cuff, sometimes we'll use these extra incisions to help us put instrumentation or little anchors in to repair the cuff. So this is a picture of an arthroscopic rotator cuff repair. At the 12 o'clock position, which is the top of the screen, is going in towards the shoulder. And at the bottom, or 6 o'clock, is coming back towards us. So that's somebody whose rotator cuff has pulled apart. So step one is an acromioplasty, which is where we shave off that bone spur and straighten it out to try and prevent the rotator cuff tear from occurring. Step two is we remove the inflamed bursa. One, we remove it so that we can better visualize the rotator cuff. Number two, we remove it because it can be a pain generator. Next thing we address is if we have to do something with the biceps tendon, or sometimes the clavicle can also have a bone spur that requires shaving off. Finally, we'll identify what the rotator cuff tear looks like. We'll add any of those accessory portals as we need to. And finally, we'll put the anchors in, pass them, and tie some knots. Sounds like a lot of steps, but once you've done it 1,000 times, it's less complicated than it appears. This is a picture of someone with a very big rotator cuff tear. On the top of the screen is in by the muscle. And if you look, there's kind of a red stripe on the bottom of the shoulder. That is where I've prepared the rotator cuff, the bone, for insertion of the cuff. You can't just take the rotator cuff and stick it on the bone because it won't heal. You have to do something to the bone to prepare the tendon to stick to it. And by shaving the bone, we create like an inflammatory and natural healing process that allows us to heal the cuff. As I tell patients, I fix stuff, I don't heal it. I do the fixing, your body has to do the healing. A big tear like this, we would put stitches to pull the cuff together, and then we'd put stitches in under the cuff and then pull it back down to the bone. This is just a picture of a really big rotator cuff tear. In order to repair that, we kind of have to bring the two ends together to kind of create, where it's shaped like is this, we have to kind of do this with it and then pull that back to bone. That's a big U-shaped tear. And this is kind of a picture of that woman's rotator cuff repair. This is a 56-year-old woman who fell at work and presented with a very weak left shoulder. On the top left is a picture of her MRI, which shows a rotator cuff tear. On the top right slide is the diagnostic arthroscopy, where we're identifying an L-shaped tear. That's a tear that kind of pulls from the front. On the bottom right slide is a picture of the acromioplasty, where we've shaved off the bone spur. And finally, on the bottom left slide is a picture of the actual rotator cuff repair. We talked a lot about rotator cuffs, as that's one of the probably the most common thing people come to see me from, whether it's impingement, bursitis, partial tear of the rotator cuff, or a complete tear. I want to jump ahead and talk about shoulder dislocations a bit. Shoulder dislocations are much less common than rotator cuff pathology. Most of the time, the shoulder dislocation, as I said earlier, pops out the front. In order to dislocate your shoulder, you have to tear structures. You can tear the superior labrum or create a slap tear. Where I say under their associated injuries, if somebody is 40 years or older, their chance of completely tearing their rotator cuff if they dislocate their shoulder is about 50%. So every decade over the age of 20 is associated with an increase in rotator cuff and other injuries if you dislocate the shoulder. This is just a view to review the anatomy of the shoulder. If we look on the slide to the, if you look at the picture to the top right, there's a socket there called the glenoid. And in the middle of it is a small area shaped like a slice of a pear called the glenoid cavity. The red stuff on the outer rim of that is called the labrum. And the way the labrum works is it gives a better, like almost like a suction cup effect to grab onto the humeral head to prevent it from sliding out of place. An anterior dislocation is where the shoulder comes anteriorly. A posterior dislocation is where the shoulder goes posteriorly. Anterior dislocations are usually due to trauma. A posterior dislocation can be if someone's trying to brace themselves if they're having like a car accident and their arm gets pushed back. I sometimes will have people who are electrocuted, and when we get electrocuted, it fires all our muscles and can dislocate the shoulder as well. The final condition sometimes are people who have a seizure can also dislocate their shoulder, often in a back or posterior direction. Shoulder dislocations, when we see someone, most of the time the emergency department reduce the dislocation, and then we're seeing them for follow-up. Every once in a while, the emergency department isn't able to get the shoulder back in the socket, and in those cases, we come in and take them to the operating room to do it. One thing I've seen probably once every other year is somebody will have a dislocation. They'll be in the emergency department. The ER will say they reduced it, get one x-ray that only shows the shoulder from the front. They don't get an x-ray from the side, and what happens is the person comes in and their shoulder's still dislocated out the back. I've had somebody come in with a shoulder that was dislocated for 3 weeks, and that is a very difficult problem to address. So one thing that's very important is working with the emergency department and urgent care to ensure that if they think the shoulder is reduced, it truly is reduced. So is there surgery needed for shoulder dislocations? As opposed to many things in orthopedics, dislocating your shoulder when you're young is actually associated with more problems than dislocating it when you're older. If you dislocate your shoulder when you're under 25 years of age, your chance of it recurring is 80%, meaning it popping out again. Once we get older and our shoulders get a little bit stiffer, the chance of that shoulder popping out again goes down. So a 20-year-old, their chance of that shoulder dislocating is very high. 30, it goes down, 40, it goes down, 50, it goes down. So the chance of the shoulder coming out again goes down. But unfortunately, as we get older, the chance of hurting something else when it pops out goes higher. So less people dislocate their shoulder when they're 50 than they do when they're 20, often because we're not as active. So let's say you've dislocated your shoulder, it's been put back in, then it happens again. In those situations, then we have to fix the structures that are allowing the shoulder to dislocate, otherwise known as the labrum, which has gotten torn. So this is somebody laying on their side, and this is somebody in a lateral decubitus position. This is most of the time how people repair the labrum. Kind of like the beach chair position, we'll do this surgery with them asleep, and also after anesthesia has done a nerve block to help with pain control after surgery. The thing that's holding their arm is a special arm holder that pulls the arm away from the body and lets us work better in the shoulder socket. This is what an arthroscopic portal looks like. That portal or that opening is about 8 millimeters wide. It looks really big on the picture because it's been magnified. But when someone has a labral repair, the surgery is completely done through these portals or plastic tubes. This is just a diagram of a labral repair, and this is just showing how we drill into the bone and we attach an anchor into the bone, and then we wrap those stitches around the labrum. If you look in the middle of the picture, it looks like a white slice. And that shape is actually the shape of the glenoid. The blue thing that goes around that is the labrum. And then you look to the top, it's almost like an apple stem or a pumpkin stem. That's actually the biceps tendon that comes into the top of the shoulder. This is a 29-year-old guy. He worked in a local factory. He dislocated his shoulder after falling off a forklift. And then that I initially treated non-surgically. And then about 3 months later, he was reaching up to grab something heavy from a shelf, slipped, and his shoulder dislocated again. He was scheduled for surgery. And then while we were waiting for it to get approved, he had another dislocation. So this is somebody who had a highly unstable shoulder. These are 4 pictures from his arthroscopic surgery. On the top left slide, that is showing the labrum, which is kind of that, let me orient you. On the top is a humeral head. On the bottom is the shoulder socket. That person's actually laying on their side, so we're actually looking at their shoulder sideways. On the foreground or off the front of the glenoid is the labrum, what's been pushed off of bone. The top right picture is now we've turned the camera 90 degrees, and I'm using a device called the periosteal elevator. And I'm elevating the connective tissue or the labral structures off the front of the shoulder in an effort to mobilize it so then I can pull it back onto the glenoid better. The bottom right picture is showing me drilling pilot holes into the bone for the anchors. And the bottom left is our final picture where you can see the blue and white knots that have now pulled the labrum onto the bone, repairing the labrum and restoring the stability to the shoulder. This is a similar situation. This is a 32-year-old gentleman who had a shoulder dislocation. He was a painter and fell off some scaffolding. And once again, on the top, we can see the labrum, which is pulled down, going from top left to top right. That's us filling the shoulder with saline and cleaning it. Then we go to bottom left, we're cleaning things, and then bottom right, now we're stabilizing them. So I'm going to jump ahead to what's a slap tear. A slap tear is the tear of the labrum from the top of the shoulder socket going from the anterior to the posterior direction. There's a whole bunch of different types. The most common thing is often we start off by treating it non-surgically. Sometimes it needs to be cleaned up and sometimes it needs to be repaired. If the biceps gets pulled off the top of the shoulder socket, now that biceps is unstable, and every time that person fires their biceps, it would pull off the top of the bone. What I'm talking about is a type 2 slap, which is an unstable one. If you look at the diagram to the bottom left, there's an arrow there showing a black space below the biceps tendon and above the shoulder bone. That's where the biceps has actually been pulling the labrum off the bone. In the interest of time, I'm going to slip ahead. There's a couple throwing things we can skip. An O'Brien's test is something that's commonly done in the office. An O'Brien's test is a test that's done with the arm brought in front of your body, and the patient lifts up against our hand, and that is actually stressing the biceps tendon to see if it's unstable. It's pretty unusual if you have a client that is diagnosed with a slap tear and with nothing else. Probably something's being missed. It's pretty unusual to have a symptomatic slap tear as the only diagnosis causing pain. It's actually much more common to have other things injured along with that biceps, whether it's the rotator cuff, bursitis, another labral tear, a rotator cuff tear. This is just a couple pictures of repairing a slap tear. The slap repair is done similar to a labral repair, where we basically prepare the bone, prepare the soft tissue, drill holes in the bone, put stitches around those structures, and then pull those structures back to bone. I just want to talk for a moment about a couple of different fractures. This is just a picture of a clavicle fracture. This is somebody that I saw whose fracture was tenting the skin. That is a surgical emergency where normally we fix them in the next couple of days so that that collarbone doesn't erode through the skin. That was done a few years back. Now we have more contoured plates that fit the bone better and actually are more cosmetically appealing and have a quicker recovery. This is somebody who broke their shoulder in 4 places. Surprisingly, sometimes we can treat these non-surgically. Patients and case managers will assume that they all need surgery, and probably 50% of the shoulder fractures that I see don't require surgery. That's all I had. And now we're going to have some time for questions.
Very good. Thank you, Dr. Kazaglis. I appreciate that.
Do I have to go off shares? What do we want to do now for the question section? Leave it on that?
Yeah, we can leave that on that. I do have a question already from Paula. Paula asks, what are some of the indications for reverse shoulder replacement surgery?
Okay. We'll talk about that. I didn't go into arthroplasty during this talk because that can be its entirely own talk. A reverse shoulder replacement needs two conditions. The person has to have a big chronic rotator cuff tear and some arthritis in the shoulder. So a shoulder replacement is done for someone who has arthritis of the shoulder. It could be due to age, it could be due to trauma, but a shoulder replacement is where you cut off the ball and put a metal ball and stem, and then you grind out the shoulder socket and you put a plastic cap on the glenoid. A reverse shoulder is a little bit different. A reverse shoulder is done often when the rotator cuff is not working properly. So a rotator cuff tear in a patient with an arthritic shoulder sometimes can require a reverse shoulder. Most of the time, a reverse shoulder replacement for rotator cuff arthritis is never their first procedure. Many times they've already had one or two attempts at a rotator cuff repair. So there's kind of a divide with reverse shoulders. One group of people who have reverse shoulders are people who have arthritis and rotator cuff pathology. You take the word arthritis and you add the word rotator cuff tear, you get a term that's called rotator cuff arthropathy. So one group of people who get reverse shoulders have rotator cuff arthropathy. A second group of people who need reverse shoulders are people who have fractures. So sometimes people will fall and break their shoulder and the ball pops off. The tuberosities that insert the rotator cuff pop off. The humeral shaft pops up. So you got basically the humeral stem is in Berwyn, the greater tuberosity is in Oak Brook, the lesser tuberosity is in St. Charles, and the humeral head is in Huntley. In those situations, especially with an older patient, if you put it back together, about 1/3 of the time it falls apart and they need another surgery. So in that category of people, sometimes we'll do a reverse shoulder replacement to basically give them good function of the shoulder without relying on the rotator cuff healing again. So two categories of people need reverse shoulders. One group are people with chronic cuff tears, recurrent cuff tears, and arthritis. The other group are people who have fractures. Just for those who don't know, a reverse shoulder is where instead of taking the ball, cutting off part of it and replacing it with a metal cap, you actually cut off the ball and you replace it with a socket. And then on the glenoid side, which is normally a socket, instead of grinding it out and putting a little plastic cap in there, you actually attach a stem and put a metal ball there. So you take the ball of the shoulder and put it in the socket, and then you take the ball of the shoulder and put a socket there. There was a Frenchman who thought of this about 20 years ago, of reversing the two things. And it's a situation where you don't need the rotator cuff to help power it. So that was a long explanation, but I hope that was helpful.
Just a reminder to everybody, we do have a little bit of time for any additional questions. So if you want to type those in now, that would be great. I know one thing, Dr. Kazaglis, especially in work comp, we see some individuals who present with shoulder pain, but the source of that pain can sometimes be from the cervical spine. Can you address a little bit how you differentiate between the two?
Yeah, so during the talk, I had talked about examining the cervical spine. One way that we differentiate neck and shoulder pain, which often can coexist, is through their history. If somebody comes in and says, I have shoulder pain that starts by my chin, radiates to my shoulder, and makes my fingers go numb, that is someone whose shoulder pain is more likely from the cervical spine. So sometimes the patient's history can give us information. Other times patients who come in with shoulder pain will keep their head tilted to the side. And I'll say, what happens if you straighten your head up? And they'll say, oh, it makes my shoulder hurt worse. That's somebody who's trying to shrink the space between the nerves in the neck and the spine to take pressure off the cervical spine. So sometimes people will come in with a characteristic appearance. We often will check the range of motion of the of the cervical spine by having the patient rotate their head, having the patient look over their shoulders, and during those tests, we'll see if it reproduces their shoulder pain. In addition, we'll do some provocative tests where we turn the head, bend it down, or we turn the head. I'm trying to do it to myself, and lift it up. And those are tests that can called a Sperling's test. That if the person is having an inflamed rotator cuff, an inflamed cervical spine will pinch it and cause pain. So every patient I see for shoulder pain gets a cervical spine exam, and every neck patient that I see gets a shoulder exam. I would say about 10 to 15% of the patients that come in to see me for shoulder pain actually have a cervical spine issue. So if a patient comes to see me with supposed to be shoulder pain and is obviously cervical spine pain, a lot of times I'll get some baseline x-rays of their cervical spine, evaluate their neck, and go from there.
I do know we have a number of physical therapists on the webinar as well. Can you speak a little bit to the role of physical therapy, maybe post-operative?
Sure. So I'm a big proponent of physical therapy. I think that it's an important augment to both preoperative and postoperative care. As I tell patients, probably about 70% of patients I see with shoulder impingement, non-full thickness rotator cuff tears, are treated with non-surgical treatment. So physical therapy, anti-inflammatories, and a cortisone shot can cure about 70 to 75% of people with impingement. So why do you do rotator cuff, or why do you do physical therapy? Most of us will say, oh, I could do that on my own. How could you possibly know what on my own means? Physical therapists provide structure and structured targeted exercises to sources of pain. I generally think 6 or 8 sessions of physical therapy in conjunction with anti-inflammatories and injection is a great initial treatment. As most adults, we're not great listeners, and 1 or 2 visits most of the time is not enough. So I would say somewhere around 6 to 8 visits is enough to get somebody on track with a non-surgical initial treatment. Now, after surgery is a different story. How much therapy somebody needs often is determined by what you did. If they have a less invasive surgery, let's say a bone spur removal and cleaning up the cuff, that person might only need 6 weeks of physical therapy. A full thickness rotator cuff tear probably requires around 12 weeks of physical therapy. And then shoulder replacement or something more involved can require a little bit longer. So I pretty much prescribe physical therapy to everybody. And generally, I try and encourage patients to seek physical therapists, either ones of ours or high quality therapy places where we kind of trust that patients get good therapy, but don't get too much therapy. I get nervous when a patient comes in and says that they already had 25 sessions of physical therapy before they see me. If someone's not getting better in 6 sessions of physical therapy, they're probably not going to get better in physical therapy. So in my world, quality physical therapists know when to turn off the therapy and change gears. And that answers a question. So.
Yeah, and I think that leads right into our next question. Eric asks, what are your thoughts on work conditioning? Is it something you often recommend for work comp patients?
I'm sorry, can you repeat the question?
What are your thoughts on work conditioning? Is it something you often recommend for your work comp patients?
So here's what I'd say. Work conditioning to me is kind of the final phase. It's kind of like where they check the NASCAR race car right before it goes out on the track for the race. So you're kind of building your way up. Most of the time, most patients, I would say 75% of patients don't require work conditioning. Just with regular physical therapy and the normal return of function, they get back to the point where they can be returned to work. I would say work conditioning is more often done with more heavy labor people. My dad was a pipe fitter. That's a pretty physical and heavy labor job. I think that for people who are working on scaffoldings, for people who are doing heavy work in a warehouse or electrical work, carpenters, sometimes work conditioning is kind of a final confirmation, and firemen as well, that they can safely meet all those job requirements. So I do order work conditioning. Generally, I do it in 2-week increments. And I'll always speak with the case manager, especially if they're present at the visit, kind of what the goal of the work conditioning is. I hope that answers that question.
Absolutely. One more question here from the group. Will you do post-surgical IMEs?
Yes, I do. I do IMEs as part of my practice. Ortho Illinois has a pretty robust work comp population, and I do IMEs as part of my practice. So.
Perfect. We've got just about another minute or so. I know Dr. Kazaglis has to get back to clinic here in just a little bit. So if you do have a last minute question, please feel free. If you do have any questions that come up after the webinar, please feel free to send them to myself or Paul, and we will get those to Dr. Kazaglis on the back end and get those answered for you.
And one thing for me with work injury is, my dad was a pipe fitter. He got hurt a couple of times, and I remember him having a case manager. He got, scaffolding kind of collapse. I remember this a long time ago. That person was an important person in his life to help them get back to work. And I always look at what I do as kind of a team approach. I was a military guy. We had privates, we had sergeants, we had lieutenants, we had captains, we had colonels, we had generals. But all of us kind of work together. And that's kind of the way that I approach medicine. I don't look upon medicine at a pyramid that I'm at the top, because if the bricks on the bottom aren't stable, the whole thing collapses. I look for more of a collaborative team approach where my clinic lead, my PA, my assistants, the patient, physical therapy, front desk, the work comp coordinator, the case manager, the patient themselves and their families are kind of all part of that team that all help get somebody back to work. So, I try and encourage a professional, cordial, and supportive relationship with all the case managers that come in my office. And, I'm there for them as well. So they're there for the patient and I'm there for both of them. So I encourage case managers to come see me, and, I give people my phone number, my email. If there's a question about something, they can feel free to reach out to me, 24/7.
Perfect. Thank you very much. I appreciate your time for this.
Thank you, everybody,
Before
for
we let you
attending.
go back to clinic, can you tell me all the different clinic locations that you practice?
Yeah. So, out in this, in our eastern area of Fourth Illinois, I see patients in our Elgin office, which is in the MOB at Sherman Hospital, on Tuesdays and Thursdays. And then I'm in our Algonquin location every Wednesday. Coming this spring, we are opening an office in Elgin. So instead of having a small office in Sherman Hospital MOB, we're going to open another freestanding structure that'll have an injury express where injured workers can come in to be seen. It'll have physical therapy, occupational therapy. It'll have an MRI. It will also have rheumatologists. So we're going to have a rheumatology center of excellence. That's the only directed or isolated rheumatology center in the western suburbs of Chicago. So that's going to be into our new building come May.
And Paul and I will both be reaching out to everyone that's on the call today and getting that information. But again, if you ever have questions, please feel free to reach out to myself or Paul.
Thanks for attending, everybody.
Thank you very much, everyone. Dr. Kazaglis, I appreciate your time, and everyone have a wonderful afternoon. Thank you.